Good evening. Welcome to the MyCP webinar series. I'm your host this evening. My name is Paul Gross. I'm the president and CEO and co-founder of the CP Research Network. We do these presentations to the community of the research that we're doing, but since it's clinical research, we're very often describing a clinical practice or a surgical practice. And I'm really excited to have this presentation tonight from Dr. Jeffrey Leonard, who's the chief of neurosurgery at Nationwide Children's Hospital. Some people who know me know that sort of the founding of this network was my now 18-year-old son, when he was about 8 or 9, was presented with the choice of we should either have a selective dorsal rhizotomy or a very involved single event multi-level surgery. And that started me on this process of trying to understand the evidence for different interventions and comparisons of them. And so I've been working with Dr. Leonard and with Dr. Bjornson for quite some time, trying to figure out the best design to study this. And Dr. Leonard's going to talk about the procedure overall and some of our plans for research. So I'll do a quick, fast introduction of the CP Research Network. For those of you that have been here before, the slides are new. Same content, but been prettified by our design firm. So enjoy. Okay, so the mission of the CP Research Network is to optimize the lifelong health and wellness of people with CP and their families through high quality research, education, and community programs. So the network focuses in these 3 areas. Pardon me 1 second, I'm going to just mute everyone. Okay, so the network focuses in these 3 programmatic areas of education, research, and wellness. In 2015, when we were founded, the first thing we did was launch the CP Toolkit from Diagnosis to Understanding, and we've distributed more than 5,200 copies of that. It's distributed at a lot of hospitals. It's really a great resource for a family if they get a diagnosis of CP for their child. I later went on to release a well-being guide for parents to really, and caregivers to take care of themselves for what can be very stressful, and went on to translate our toolkit into Spanish and Portuguese. And then we launched MyCP in 2020, which really enables you to get personalized information about your CP or your loved one's CP. Our research program is our biggest program. We started out to create a registry, so a database of people and the characteristics of them. And we launched that in March of 2016 in our second year. And we have about 7,500 people that have been enrolled in that. And then we launched our community registry, which is intended to collect information about people's experience in the community, not in the clinic or in the hospital. And we launched that in March 2019, and it now has over 1,600 people in it. We are very focused on being patient-centered in the research we do, nothing about us without us. My co-founder, Michelle Schusterman, and I are both parents of children with CP. And so we put together an effort to develop a patient-centered research agenda, which was published in 2018 and really is essential to our work. We've gone on to get some significant funding milestones from both the National Institutes of Health and recently in partnership with the largest private funder of CP research, the CP Alliance Research Foundation. We run both research efforts and quality improvement. They're both ways to improve outcomes. We've got 4 efforts in the network right now, and I'll talk about those in a little bit more depth in a bit, that we launched in 2020. And then academically, we try to produce information or generalized knowledge from the work that we're doing, which we can then roll back into clinical practice. So we've had 9 publications to date, over 27 academic presentations, and we've got a lot of new manuscripts under development from the research we've constructed. And then on the wellness front, our main focus going forward is our partnership with the National Center for Health, Physical Activity, and Disability through their program called Mentor, which stands for Mindfulness, Education, and Nutrition to Optimize Resilience. So the network is a 501c3 nonprofit organization, and it basically works to organize the field of institutions, clinicians, therapists, researchers, and you as community members to really improve outcomes through conducting research. Physically, we have a data coordinating center where these registries or databases sit, based at the University of Pittsburgh's Epidemiology Data Center. And we have both our clinical registry there and our community registry. And then we have our education and well-being programs. We focus a lot on getting the community to engage in research. And our way of doing that is through MyCP, which is this free personalized web portal that sits inside of CPRN.org, sits inside of our network. And it offers you the opportunity to participate in the community registry through surveys, to engage in discussions about research and your lived experience, to get these personalized web services, and to access our free wellness programs. So if you're not already a member, I would encourage you to sign up for free, mycp.com. So I want to talk about 2 data points that we collect of the many data points in both of the registries to give you a bit of comparison. So the first data point on the left is called the Gross Motor Function Classification System. This is a way that people with CP are categorized based on how they move around the environment. Are they ambulatory or do they use a wheelchair? And then some degrees of detail within there. So what you see on the left is when our registry had 5,200 people, you see the distribution of people across those levels. 1 through 3s are independent ambulators, 4s and 5s are wheelchair users. And so you see sort of a U-shaped curve. And then on the right is just a bar graph of the ages of people that we are capturing information about in our clinical registry. And you can see that we have a little over 20% of our people are adults. So it's kind of a bell curve. And I'm going to compare that now to what we find in our clinical registry. In our community registry. So here, anybody can participate, not just people that are being seen in our 30 centers. And you see a very different distribution of people's ambulatory status. And that's because there's a natural bias of who is online and spending time like joining things like MyCP. And then from an age perspective, you also see a very different curve that instead of being more bell-shaped, it definitely leans to the right. We've got a lot more adults that participate in MyCP relatively than you find in our clinical registry. So those are our programs. I talked about education, research, and quality and health and well-being, but then also really this focus on community engagement. And this is the group that gathered in Chicago in 2017 to set our patient-centered research agenda. And these are our researchers up here in the top left and some of our toolkits. So the network is spread across North America. What you see here are the green pins or sites that are collecting data into the registry. The yellow pins are preparing the registry. The red pins are working through some compliance and IT issues. The blue pins are sites that have raised their hand and said they want to join, but they have not gone through the process fully of joining yet. And then the green circles are the sites that are lifespan centers, and they're treating both pediatrics and adults. So our core reason to exist is to improve outcomes, and research is our biggest program to do that. We have a funnel that we've been filling over the last 8 years of ideas that we think are important to study based on the input from the community. And then we move those forward into an application to get funding for research. And then if it gets funded, we move it along and we implement the study. And from the study, we generate evidence and we publish. And then we use that to try to change practice. The green ovals are the quality improvement efforts. The off-white ovals are the studies we're conducting. And tonight we're going to talk about selective dorsal rhizotomy effects and selective dorsal rhizotomy overall. So with that, I'm very excited to introduce Dr. Jeffrey Leonard, who's the Chief of Neurosurgery at Nationwide Children's Hospital and a Professor of Neurosurgery at Ohio State University. He's in an endowed chair position, which enables him to do more research. And he is a member of the CP Research Network Steering Committee. And he is one of 3 principal investigators in this SDR study that he will talk about a bit. So with that, I turn it over to you, Dr. Leonard. And you'll need to unmute yourself in addition to, let me stop sharing my screen.
All right, thank you, Paul. Let me see if I can get this share there. Can you see it?
Yep.
Okay. All right. And we're back at the beginning. All right. Well, thank you very much for having me tonight to talk a little bit about what we're going to refer to as the conus rhizotomy, which is the way that most centers are currently doing rhizotomies around the United States. We're going to talk a little bit about the definition of cerebral palsy, the definition of spasticity, and why the rhizotomy works. We're going to talk a little bit about treatment options and compare them. We're going to talk about nerve root identification, the key to being able to perform this procedure correctly, and then compare some of the different treatment options according to your various ambulatory level. And I like this picture because the purpose of the rhizotomy is to get the folks that are actually standing on their toes flat. This is a family, when I was first here, actually showed me this picture, and it sort of encompasses everything you're trying to accomplish with the rhizotomy, and it's very simplistic in nature. Now, CP is very common disability, costing a lot of money over the course of a child's lifetime. This is actually a golfer in West Virginia that is one of the top golfers in the state of West Virginia. She does have CP, a spastic diplegia, as you can see, and actually has done quite well after her rhizotomy. This is a non-progressive disturbance in most situations in developing fetal or infant brain. Hypertonia is accompanied by loss of selective motor control, which is what affects our gait. It causes, as children grow during this time, a lot of secondary musculoskeletal problems, which deformities, contractures, and other things that really affect pain, really affect the ability of these children to get around, and really causes them to sometimes lose their ability to ambulate later on in life. Now, the definition of spasticity is a motor disorder characterized by velocity-dependent increase in tonic stretch reflexes. There is an exaggerated tendon jerk resulting in hyperexcitability of the stretch reflex. More simplistically, what it does is you have both sensory and motor neurons which talk to one another. As you get an inhibition of inhibitory input from the surrounding brain, these become quite extensive, and your increased sensory input causes an increase in the motor input and causes what we see in most kids is spasticity in their lower and sometimes upper extremities. And it happens in both, because in one side can obviously affect the other side as well. Now, CP is generally considered a non-progressive condition, but as you can see from this graph, as we move across the child's lifetime, there is a decrease in function that occurs, especially in your more highly affected individuals. This decline is especially evident in the middle to late teenage years as a child are going through their greatest growth spurts, because quite simply the muscles can't keep up with the growth of the bones and the legs, and you get the associated contraction and deformities and pain that really limits their ability to ambulate. But any discussion about the effectiveness of interventions must take into account the heterogeneity of the disease and the natural history. Variable evidence exists for all the various interventions, Botox, SDR, as well as multi-level orthopedic surgery. This is commonly done to address contractures and bony deformities. The goals of treatment must be to improve the activities of daily living, decrease the number of orthopedic deformities. There is some benefits to spasticity. Sometimes a lot of children and teenagers use these toned aids in sitting, standing, and walking. So you must evaluate that when you're deciding what the best intervention is. Muscle contractures may prevent DVTs, and tone adds muscle bulk to pad the bony promises. So you don't get fewer decubiti ulcers when you're talking about dealing with children with CP. And it may also be useful with bracing. Now, as Paul was showing, most of the children with CP are ambulatory. And that's what I mean when I talk about GMFCS 1 to 3. Another 30 to 40% are the children that we commonly see in wheelchairs that have a lot of other comorbidities that really make choice of any sort of intervention in their case quite important. Now, Paul talked a little bit about real world treatment with choice of rhizotomy. And what you see here was when you go around to the various institutions, there's often you take a single patient and plop them in one of three institutions, you're going to get three different answers as to what your first line treatment for these children. Each institution within this Midwest area is within driving distance of another. How does this happen? This occurs because we're going to talk a little bit about these variability and evidence between the various interventions. Many treatments of spasticity were adopted and inadequately evaluated prior to being adopted at various institutions. Reliable outcome measures have been developed, and what we're currently doing within the Cerebral Palsy Research Networks is beginning to evaluate these in conjunction with one another to be able to advise the families as to what the best option for their particular patient, for their particular family member will be. Alternative spasticity treatments, as I said, include Botox, orthopedic procedures, as well as other neurosurgical procedures. So most of these that I list here are historical, except for placement of the baclofen pump. Now, Botox. Botox is something that a lot of you that have had spasticity or had children with spasticity see. You use it quite often, and oftentimes this may be the first thing that you start with. There are randomized trials showing Botox, when compared to placebos, does reduce calf spasticity and does increase ankle dorsiflexion. It also shows that it's able to delay the need for and frequency of orthopedic procedures. So it does have a benefit. But then you're going to turn around and ask me, is it better than SDR, which is a permanent procedure? There are no studies comparing the two, so I can't tell you that there is that one is necessarily better than the other. Semels. Semels are defined as two or more soft tissue or bony procedures on two or more anatomical levels. There's a lot of studies that study this. Trends toward more favorable analysis gate were evident, though there is significant variability in study quality. Retrospective, this is one of the only ones comparing ambulatory children who underwent single level orthopedic procedures and SDRs. Better dynamic controls associated with improved outcomes, regardless of treatment. Treatments associated with the ability to improve motor control, improve outcomes. So not a real clear dividing line of Semels versus orthopedic procedures for this particular study. Though this is from a very member of CPRN that basically stated once that the overall quality of evidence in support of multi-level orthopedic procedures for ambulatory is weak, based almost primarily on uncontrolled case series, looking at pre-post interventions with very few comparative studies, basically demonstrating that we have a long ways to go. So let me focus a little bit for the remainder of the talk, mainly on rhizotomies, because that's what you're all here to hear about. What is a rhizotomy? Rhizotomy is the cutting of nerve roots. It was first described in the 1930s. And a lot of people basically in work by Sherrington and the work on the physiology of posture. It was first described in 1888 for pain relief and first started really in earnest in the early 1900s. Though what people noticed is that when you had something that affected the sensory nerve roots or diseases, these children didn't have spasticity, so they began cutting all the nerve roots. However, the division of all these nerve roots produced significant amounts of neurological problems where you didn't know where your limbs were. You had problems with bowel and bladder function. So it really did not take off until really the 1950s or 60s, because what it did was, this is what a rhizotomy does, showing that when you inhibit the sensory input, you have decreased excitability to the ipsilateral and contralateral motor neurons. But it really didn't. This is one of the first studies here, review of 159 patients with congenital spastic paraplegia, responded favorably in the 1900s, but there was all sorts of other neurological problems. It really didn't take off until the 1960s and 70s when they began adding electrophysiology to this. And what electrophysiology does is it allows you to really tell which of the nerve roots you're grabbing, which of the ones you're testing, and which of the nerve roots are you going to section. They also adopted monitoring of anal sphincter. And what that does is that almost, if not always, eliminates the potential for bowel and bladder dysfunction after this procedure. Peacock, who started this procedure doing multi-levels in the 1980s, demonstrated 60 patients with very good results in reduction of spasticity. Everybody's seen this. This is ambulatory children evaluated down in Texas, and as you can see, there's significant toe walking, and they can see what happens when they When they jump, can't really jump, and that's what they walk with. And I'll show this child a little bit later after a selective dorsal rhizotomy to really show how we're able to immediately affect these children. So really for the performance of an SDR, it's really identification of nerve roots and nerve root criteria through electrophysiology is the critical part of this. The enthusiasm attempt, because they're concerned about long-term effects. And I'll show you the studies as they exist for long-term effects. And there's also recognition that large uncontrolled studies are capable of bias. Now, I must say that I come from St. Louis, which is one of the largest centers to do rhizotomies, and we do have we have not performed the comparative effectiveness studies that really compare this to either semos or to Botox injections to really answer this question. Now, what this also shows is this is a study that Paul did, which demonstrated decision-making with an SDR. And what you can see is that there's a significant variability depending on who you are and what's your youngest age for SDR, as you can see, depending on who you're asking, developmental pediatrics, orthopedics, PM&R, which is different types of physicians, as well as neurosurgeon. There's a wide variability as to when you're going to consider SDR. Age when they receive SDR, you can see most of these children are receiving them between the ages of 4 to 8. Some will go as early as 3 to 4. Some will go even older than that. And what's your oldest patient for SDR? And I'll be the first to admit that I'm the one that'll do the patients that are greater than 18 years of age because of the properly chosen patients. They do quite well, but as you can see, there's wide variability depending on what profession you're asking that question of. Surgical decision-making, and we'll talk a little bit about some of this, and they can see as you were stringing for dystonia, which is another widely, which affects outcomes following performance in SDR, and your perception of the ideal GM-FCS level. And I'll take a little minute for you guys to read this. For those of you that, I'm going to move a little bit. What is your typical level? As you can see, most are the ambulatory children, okay? Now, this is for another registry kind. As you can see, this is the number of SDRs we at one point actually had in the registry. This is SDRs, and you can see here the various people that are getting the SDRs within the registry based on age. You can see almost 25 in the registry have SDRs, which are greater than 18 years of age. ITP pumps, a little bit more variable. Orthopedic procedures, more variability with, again, as you might expect, once development has taken place, the older patients are the ones getting the semos. You can see GM-FCS levels with most patients getting that are ambulatory GM-FCS 2s and 3s, but there's also a significant number getting palliative rhizotomies, which are rhizotomies that are done to the non-ambulatory children for hopes of allowing them to have greater ease in performing activities of daily living and decreased pain. Another thing that nationwide is experienced, where we're getting most of our children are coming from large metro areas, and we're seeing some difference between metro versus other locations in those, our total population of CP versus our SDR population. Racial background, we want to make sure that no matter what your race is, that you're getting offered a particular procedures. And you can see white patients, there's a little bit of a discrepancy between Black and African American that we're attempting to delve into with this particular procedure. Now, how do we evaluate for an SDR? Preoperative evaluations, we look for hip subluxation or dislocations. We look at the lumbar spine. We get an MRI of the brain when we have term infants, or any sort of abnormalities that are lower back pain in adults that we're adopting for trying to undergo SDR. We do gait analysis on most of our patients, which I'll show a little, and we look for fixed orthopedic deformity because reduction of tone is not going to really improve the ambulatory nature of those children. Now, the main part of this procedure is partial deafferentation. We're cutting between 60 to 75% of the nerve roots. We do EMG testing of all these nerve roots, and we do it, as I told you before, I come from St. Louis and TS Park. There's a single level laminectomy. We use the ultrasound to localize the conus. And for those of you that want to know what a rhizotomy is, this is what it looks like. We position the children prone on the bed. We take off the one level laminectomy. And then we begin stimulating each of the nerve roots. And what does that look like? This is how we localize the conus. This is what the tip of the spinal cord looks like under ultrasound, which is a perfect location where I'm going to tell for those of you that can see this, this is the dorsal nerve roots versus ventral nerve roots. And we divide this out here and begin to section those. What does that look like in the operating room? It looks like spaghetti. And what this does here, let's see if I can get it going. So what we do is we selectively dissect out all the various nerve roots. And what I've done is with the piece of blue soft side elastic there, I've divided the dorsal from the ventral nerve roots. If I cut the motor nerve roots at this time, the child is going to be weak or the patient is going to be weak underneath there. So what we do is we divide them out, and you can see each has little fascicles that we divide out, and I'll move it through it in the interest of time. There we are stimulating them, and that tells us what level they're actually at. And then we end up dividing it out. So when patients have pain after a selective dorsal rhizotomy, this is why they have pain. They have significant neuropathic pain that takes about 3 to 5 days to get to recover from. Then we stimulate them, and then go on to the next one, and do the same thing on each side. I actually did one today doing exactly this procedure. There are other modifications and other procedures that do more. This is out of Seattle, where they do modification to the single level laminectomy, where they do below. What the key here is, it takes much longer because you have to stimulate all the nerve roots, because you don't have the anatomy to tell you the difference between the dorsal and the ventral nerve roots. We look at stimulation thresholds. This is for, I won't spend a lot of time on this, but these are the stimulation thresholds that allow me to tell the difference between motor and sensory nerves. We use anatomic isolation and separation. We use mechanical stimulation to tell, because the ventral nerve roots will produce a mechanical stimulation. The lower the threshold, the more I have to be concerned about the fact that I have motor nerves. We use grading of this, and what we want to do is identify the nerve roots that produce the response that are outside their dermatome, or sometimes these responses can even carry to the opposite side. We have different variability in grading. We use the Phillips and Park grading scheme, which has been significantly reliable for us. We end up, usually takes about 30 to 45 minutes to perform this per side. We may divide out and section probably 44 nerve roots per side or thereabouts. And that produces a significant amount of pain. So what we do is, at least for our procedure, we keep the children flat for about 48 hours. Now, what this has done, the use of an epidural catheter, has really reduced the need for narcotics in these particular patients. And by days 3, they're up and participating in physical therapy, a recent publication from pediatric neurosurgery. The main complications that we see are sensory disturbances lasting 1 to 2 weeks. We see, with the development of the one-level laminectomy, we see no evidence of spinal instability. I think I've fixed one procedure over the past 13 years that has developed some subluxation as they have grown. We have very minimal CSF leaks and very minimal infections in practice. Really patchy sensory loss is all we see. We are taking advantage of bisections of the fact that the legs have a lot of overlapping sensory dermatomes. There is significant variability existing in the postoperative care. I like to tell people that when I do this, that my job is actually easy. It's over within the first 3 to 4 hours, but the children and patients that undergo the rhizotomies are requiring to do physical therapy for long periods of time afterwards. These goals are established before the procedure and impose very important part of the postoperative therapy. This absence of tone that I produce by this procedure allows for strengthening of the individual muscle groups, something these patients could not do before. We usually try to recommend physical therapy, but as you can see, we don't get it. And we're also beginning, with the help of Christy and Bjornsson from Seattle, we're beginning to examine what types of physical therapy actually affect the outcome in following selective dorsal rhizotomy. The other thing that you guys will commonly hear about is single level versus multi-level. There's several institutions across the United States that do multi-level SDR. There's only one study that comparing the two. Usually PT is usually commencing day 2 to 4 for single level procedures. There's similar gains of function. They're almost equivalent, though we've taken and reduced the incidence of spinal deformities from 20% to almost 0 with the development of the one-level laminectomy. Well, so what does it look like for the patients? These are the gait studies that we see. And we do gait studies 1 year afterwards. This is actually a GMFCS level 2 done at age 4. And as you can see, this guy used to slide down his belly, go up handrails or on hands and knees, usually uses a posterior walker. This is done 1 year afterwards. As you can see, his gait has significantly changed. It's variable day to day with handrails, sometimes scoots, but as you can see, he can now walk independently. So this is showing the age variability, and this is another GMFCS, but this guy's 22. This guy actually just run his first 4K after his dorsal rhizotomy. He just ran it about 3 weeks ago. And as you can see, there's no way he's running a 4K when he's doing it before. But now, done a year after rhizotomy, you can see he's putting his feet down flat. He's able to have good selective motor control, and he's been working very well on the strength, and he's really going to do quite well after his selective dorsal rhizotomy. And he has no further trips or falls, which was his major complaint beforehand. So how do the more severely affected children do? Reverse walker, pain in calves and frequently. Gait pain afterwards, as you can see, no longer using his reverse walker. This is almost a year after surgery. Still has significant problems getting his feet down, may require orthopedic procedure afterwards, but a significant change in his gait pattern following a selective dorsal rhizotomy. What does that look like in conjunction? This is sort of a summation of a number of our patients, less than 10 and greater than 10 years, that have 2-year follow-ups. And what you can see, we're seeing a reduction in both upper as well as lower extremity of all of our, when we do the selective dorsal rhizotomies. We're doing them with children that have typical findings as well as other genetic syndromes that all demonstrate spasticity as well. And this is really fun because we're really beginning to examine our results in a very real-world fashion. Now, any talk about selective dorsal rhizotomy wouldn't be the fact that there's actually, a real 3 randomized controlled trials that have shown that selective dorsal rhizotomy works. This is actually a meta-analysis of the 3 combined trials. There they are from Vancouver, Toronto, and Seattle. They've shown that there is Ashworth scores, GMFMs, GMFM 66s, and what it showed is the Ashworth scores confirmed an overall reduction in spasticity. It showed the gross motor function measures, pooled results confirmed that SDR plus physical therapy resulted in improved motor function, and showed there's a positive association between the number of nerve roots cut and functional improvement. Another more recent study showing SDR improvement, both function and quality of life 2 years after SDR for ambulatory GMFCS 2s and 3s. In summary for this, there's very good evidence for the ambulatory children. So long-term benefit, because everybody wants to see, well, if you do it, how long is it going to last? There's a number of studies showing 10 and 15-year follow-up showing you get continued reduction in the in your spasticity scores after this. You also get from this you get changes in your GMFM or improvements in your GMFM that persist up to 15 years after rhizotomies. And the long-term studies also show this as well. Study cohort including 24 patients with SDR and 11 patients without. Larger improvements in gait pathology required more interventions after SDR. So good long-term outcome measures. And this one, actually, this is kind of a fun story. This is one of the very first patients that I did. You wouldn't tell it. She was a physical therapy, she was a trainer, worked out every single day, and she has a very normal gait. This is 3 years after she had her SDR. Now, what we've been able to do is reduce the amount of orthopedic procedures that we do after SDR. We reduce the need for Botox. And for Botox injections, for those of you that have had it, they start and work very well in the very young kids. But as you get older and heavier, it starts to have, because it starts to have less and less of a benefit, because you can't get enough to actually produce the benefit that you saw when the Botox was much younger. There's durable improvement in lower limb tone, gross motor tone, and performance of ABLs for patients with that have fallen SDR. So dorsal rhizotomies and quality of life, as you can see, it also has significant effect on quality of life, and it has significant up to 20 to 28 years afterwards too. This is a summary chart from T.S. Park's recent paper that 95 patients undergoing rhizotomies 2 to 18 years. And as you can see, almost 90% had an improved quality of life, with 42% having a higher level of ambulation. Case control study, 22 years out, done out of Michigan and Ed Horowitz. Case with SDR 38 and 50 comparison, 22 years after SDR, did not significantly predict pain interference or pain intensity or fatigue. SDR was related to lower decline in gross motor function, and 6 hours laid less assistance. So it did have effect even 20 plus years out from an SDR. So most people would actually say it is something you should consider for children that are ambulatory. And what is also emerging is you may also want to consider this for your non-ambulatory, because it is much simpler to maintain and an effective alternative for patients that aren't necessarily great candidates for baclofen pumps. Effective selective dorsal rhizotomy on daily care. This is SDR in treatment in patients that have dystonia and are non-ambulatory. And as you can see, there is significant improvement in activities of daily living or daily care after a performance of an SDR. Probably the most valuable comparison study showing 71 patients who underwent SDR or matched with 71 patients who underwent ITB therapy, matched by age and GMFCS, and these are the GMFCS 3 or higher. And what this trial showed is that SDR provided a larger improvement in tone, passive range of motion, though fewer patients required orthopedic procedures, but both procedures, in interest of complete disclosure, had a high degree of patient satisfaction. Gait analysis, where do we use gait analysis? It really allows us to define the goalposts both before and after, but I also want to provide a little bit of a caveat with gait analysis as well. It does alter surgeons' decision-making some of the time, though there is one study showing that 11 patients across 4 centers produced varied treatment results in 9 of the 11 patients. So there's still, within the real-world evidence, a lot of variability existing with the recommendations for these particular patients. And everybody will remember this patient. And as you can see, this is him in rehab, and I have rehab going on for 2 weeks after an SDR. It's showing an improvement in ambulation and motor function. There's decrease in orthopedic deformities, and there are some modifications that we continue to strive for to reduce the impact on these children. The tone reduction for this is necessary. Selective dorsal rhizotomy is an excellent option, and these results are durable with very few complications. Further studies directly comparing each therapy need to be done, because it's one of the major holes that we see. Because this is what we want to see. A child that could never stand up straight beforehand is now able to do that. As Paul has shown, this is an older study from CPRN, where we have a lot of clinicians doing this. And to emphasize here, recommendations for therapy for children with CP is a team sport. And Christy Bjornson is on here, and I would a complete shout out to her and the team that is currently trying to put together a grant, a comparative effectiveness grant, to study SDR compared to all the other interventions that are potential in ambulatory children with CP. We're doing it through a variety of a U mechanism, and these defining the 2 phases. This is an observation, permit both scientific and operational planning activities for the first phase. And the last phase, lasting up to 5 years, will begin to study SDR versus all the other interventions that these children undergo. There's significant lack of evidence supporting decision-making within the real-world settings. SDR versus all the other therapies that we very quickly covered in this talk. This basically fact contributes to significant practice variation in who is offered SDR. Clinicians often rely on training and personal bias when deciding which ambulatory patients with spastic CP warrant referral. And this is one of for parents and patients that have CP or have children with CP is one of the most difficult treatment decisions, as Paul alluded to earlier in his talk. So what we're deciding here is we're deciding a study that is really going to match SDR versus non-SDR patients over a 2-year time course. We're going to look among 20 clinical sites across the country and into Canada. We have a primary baseline at 1 year and 2 years. We are going to include these patients. We're looking for all 13 to 18-year-olds undergoing evaluation for spastic CP who are ambulatory GMFCS levels 3 or less. we are looking for no genetic or progressive neurological causes of spasticity, and they must be willing to commit to follow-up for the 2-year period of the study. What we're looking to do here is first screen the patients for those that could potentially be evaluated for SDR, and that's what this says with a lot of words. And we'll then evaluate them and match them, SDR versus non-SDR pairs, to be able to match them by their gross motor function score, as you can see, GMFM 66, as well as their goal score, which is a measure computed by the parent as to how the patient is doing. We will look at this over the course of the 2-year time period. We'll also look at SDR frequency and utilization of physical therapy, as well as therapeutic injections and orthopedic surgery. So we want to see what further therapy is required to manage these children's spasticity. We believe that children that undergo SDR will be associated with a higher frequency and longer duration of PT, but will have fewer therapeutic needs and fewer needs for orthopedic surgery after undergoing that procedure. We'll also make sure that we're offering these patients to everyone that will benefit. We want to make sure that age, sex, race, and ethnicity don't factor into, as well as socioeconomic status, don't factor into who is recommended for an SDR. We want to make sure that we understand the importance of dystonia in functional outcomes. And we'll use these patients that undergone SDR. And we believe that this is, as you can read here in our hypothesis, the younger age, male sex, and non-Hispanic white, not having dystonia, will have a greater improvements in GMFM 66 and goal scores, respectively, following SDR. We'll also quantify the physical therapy intensity, frequency, time, and type. Dr. Bjornson is an R01 funded investigator that is doing exactly this through her, and has a mechanism to do this through her current R01s, and is championing this particular part of the grant. And I'm really excited because this is a very key piece of SDR treatment that is really with insurance companies. Is for those of you that have filed with insurance companies, the ability to obtain physical therapy data is quite important. And this hopefully will begin to answer the importance of that over the course of the treatment for children following SDR. And what I'm going to show Paul's chart here, but in a little different form. CPRN has come a long way since I first got involved in it. This is one of his original charts here. And as you can see, it's very, very sparse, shall we say. But over the course of a very few years, with developing a very core set of investigators and excitement about both within the community and within the investigators and centers that are producing SDR, he's produced this. And I really would like to commend him for generating the excitement for research in CP. And I hope this current pipeline that we're developing within CPRN continues to fill. And we also see off branches for more and more R01 or NIH funded grants to really study these questions in a real world setting. With that, I want to thank you, and hopefully I didn't take up too much time.
Thanks so much, Dr. Leonard. That was great. I want to stop your one more thing, and we'll be back to sharing. So there's already a few questions in the chat, and so I'm going to just read those to you. One was, is it possible to have an SDR after a patient has a single event multi-level surgery?
Yes, it would depend on monitoring gets a little problematic at that time. You just have to know exactly what they had.
Okay. And then
and I should also say, predicting results, it gets a little problematic at that point.
So it's a little bit less of a known.
Correct.
Okay. Chris Geddes asked, it appears to me from the lived experience of SDR could help reduce spasticity in adults, improvement in the length of walking. Oops, sorry, I just scrolled for me. It would occur to the loss. Actually, Dr. Leonard, could you read it and you can answer the question? I'm stumbling over my words reading it. Failure to do an SDR in childhood puts many adults at risk. My experience is Gita Veru, the hamstring tightness, plantar fasciitis. Comments. I believe studies should.
Is it in the chat?
It's in the chat. I'm trying to get to the question. I
It's
believe
not to
studies-
everybody, Paul. The question isn't to everybody, so
Oh,
Yeah,
I'm
I
sorry.
don't have
Jeff can't see it. Jeff can't see the question.
That's why. So thank you. I didn't notice, Christy. So the comment is, I believe studies should be done to do this in adults to allow greater benefit of maintaining childhood function into adulthood. Review patient to age 30 to 40 to maintain walking. So it's a comment. Any thoughts about study of this in the older population? You're demonstrating that you are doing it with certainly teens and young adults.
I think it gets, and I'd like to hear Christy's answer, but I also want to hear Christy's opinion on this, because the first thing, it's a team sport, because you have to. There's a lot of things that go into once you've reached adulthood, you've fully matured. So what we see in the adults is we see more fixed deformities. In some of these kids, we can have where they develop weakness, where they haven't been able to, where they've used tone to ambulate and improve their function. So that's gonna prove difficult. They also have needs too, where they can't take the 2 to 3 years out that are required for physical therapy. So these are all things that go into a very shared decision making that have to go into SDR. I guess the short answer to that, adults are not out. I am the properly motivated adult that has a very focused set of goals is somebody who I'm very willing to do an SDR on.
Right.
Christy?
Amber asked specifically, what's the maximum age that you...
Let me ask. I want to see what Christy has to say about this,
Oh, I'm
because
sorry, go ahead.
I take physical therapists' opinion about this very, very carefully.
Yeah, I would just say that if they're purely spastic, an adult patient can have an excellent result. It's when they have other dystonia or other things going on, and they're very debilitated. They almost need to be prehabbed ahead of time to get an optimal response the bigger they are. And also you have the musculoskeletal deformities that would be present in an older, an adult. So that would have to be considered as part of the team decision. And also, how much time are they willing to put into rehab? It's no different than an adult having a total knee or a total hip.
Right. It's a very good point. Denise asked, is or should an SDR be localized to the muscle group that's showing spasticity clinically?
Yes, we have a very good, it can be. So I'm going to answer that 2 ways. Like, for instance, I am doing SDRs on hemiplegic kids, and there are some of the best results that I've seen, and I've been able to return some of them to walking almost normally. We are getting more selective in that we have children that have just ankle problems or ankle spasticity. The one thing is I test all the nerve roots when I do it, because what I want to make sure everybody understands is once you get it's a one-time deal. Once you do it, you cannot go back. So you need to make sure that you get away with the most that you can get away with.
Yeah.
Does that answer the question?
Yes, I think so. What is the maximum age you can do an SDR?
I haven't reached it yet.
Okay. Yeah, I mean, I know of a 25-year-old that got one. I don't have heard of older, but have you?
I've done a 40-year-old. I've done a 40-year-old.
And how did they feel about the result, and how did you feel about the result?
He's a baker from Atlanta, and he sends me stuff every single month.
Okay.
So
it sends you food, or it sends you updates on how he's doing?
Both.
Okay.
So here's what he had pain when standing. He had trouble getting around over the course of the day, and he's now 6 months out, and he's completely changed. He literally is having no further problems. He lived alone, and he just wanted to go back to work and be able to work for an entire 8-hour shift. And he was like exceedingly motivated. He was doing stuff before the rhizotomy. He was an ideal candidate. So when I get in that situation, there's no age limit.
Okay. Connie asked, in the study, how many years will you follow patients thinking about orthopedic procedures that may occur much later than 2 years post SDR?
Well, I'm following them 3, 4, 5 years out. So I do think you will see improvements within that first year in the less severe kids. It may take kids that are GMFCS 3s or greater upwards of 2+ years to begin to see benefits from an SDR. So what we see with the orthopedic procedures, there's about a 9 to 15% of kids that receive orthopedic procedures during their first year. That increases as each year goes on. So I want to make sure that people know that when you do an SDR, it doesn't mean orthopedic procedures are going to go away. You or get few of them. Because like, for instance, if you go to St. Louis, everybody gets Achilles tendon lengthening when they do it. So there are things that have to be done. Like, for instance, the kid that I showed, the GMFCS 3 has had orthopedic procedures since that time.
And two things I would add. One is, it's my dream that when we're done with this study, before we finalize, we will submit it won't quite be a competitive renewal, but we'll submit a grant to follow the SDR kids longer and have a question that we can answer. And if we can't do that, 17 of the 20 centers are part of the network today, and I certainly hope by the time we're conducting the study, they'll all be part of the network. So we will not have the same rigor of following them, but I'm hoping we'll be able to follow them in the registry for quite some time. So Poonam asked, what are some of the worst outcomes you've encountered with SDR at St. Louis versus not St. Louis practice? And if some adverse outcome is seen, there's no going back, or is there?
Well, I'm going to answer that this way. I think when you evaluate an ambulatory children with CP, you have to take into account what their follow-up is, what their muscle tone is. So, for instance, if a child comes in with legs that are thin as all get out, has Ashworth scores that are significant, and can ambulate, but is using the primary tone to ambulate, if I do an SDR in that patient, they're going to lose their ability to ambulate. They may just ambulate for transfer or walk from, in a walker, across the room. But if they're using tone to do that, that's going to be a worse outcome. If some of the kids that have dystonia that are GMFCS 3s, that wasn't completely appreciated prior to the procedure, are not going to have as good outcomes as those that are pure. And that doesn't mean you can't manage them. It means you have to employ multimodal therapy to manage both their spasticity and dystonia. So I do believe it's a team sport. And I do think that at Nationwide, and I think Christy will attune to this, that having the therapists, having the orthopedic procedures and everybody else is probably the best way to do it, which is what we've tried to do.
Jeff, let me ask you one question that is a little bit, just because you had a very rich presentation, and I'm going to not ask you to explain all the things that I needed to explain, but are you okay staying on a little bit after, because there's a fair number of questions?
Yeah, totally fine.
It's late on the East Coast. Okay. Amber, you're up. You're muted.
So what is the biomarkers or the criteria to determine who has pure spasticity? Because I'm hearing you say that that's the most optimal diagnosis to do this procedure on. And what if you're like an asymmetrical quad, or you have other sensory issues, which most people with cerebral palsy do on some level? Yep. How do you factor all of that into that?
So first, the best one is to really tell that there's no biomarkers per se. It's done based on physical exam. And because of the length, I covered it fairly quickly. There are a number of tests that you use to really determine whether you have dystonia or what part of it. And you should know as you get more severely affected, the presence of dystonia or the fact that you have just purely spasticity, you're going to have more people in the more highly affected individuals are going to have dystonia. So I just warn people, sometimes you may not appreciate it. And once you take the spasticity away, you may see it after the procedure. So asymmetric, we still do everything. The nice thing about this procedure is I still do it the same way for most parts. And what it's done is the reason for the 60 to 75% or 80% is that doesn't produce sensory changes in any of these children. Maybe some distal sensory loss, but I have probably the second largest cohort beyond St. Louis as far as, and we're just not seeing those complications. So I've just seen that really, you know, I probably, if they're having pre-procedure sensory problems, we will, you know, we'll basically counsel the family as far as that goes. And the other one to say is, what I can't do, I think what you're indirectly asking me is, do I cut less nerve roots? And what we've seen in some of the studies that if you don't cut over 50% of the nerve roots, you're going to get return of spasticity at 6 months. So you need to make sure you push it above that level, because what I tell families is that at about 6 months, you may get a slight return of spasticity, never to the same degree it was, but you're going to get some variability in there, and it may be a little greater in the more severely affected children. Did I answer your question? Or
I think so. And so the part about pure spasticity, you see the best results if you can identify that. Is that correct?
Yes, you see the best results. I think what we're saying in the study, and I covered dystonia a little bit, is there's a lot of clinicians that will think you can't undergo a rhizotomy if you have dystonia. And I don't think that's true. You need to counsel the families as to that will affect your results. And then you can turn around and do a rhizotomy and follow that with medications to control dystonia. You can talk about things like DBS if that's an issue. You can go to multimodal therapy. It's not something you can't manage. But what is terrible and what I've seen is I've seen children that are come and they're all contracted. They developed fixed deformities. And everybody just said they have dystonia, so I can't undergo a rhizotomy. And you've really lost your ability to intervene at that point. I think there are ways and tools that we have to manage each of those things.
Okay.
Thanks. So Dr. Leonard, I'm going to take the next question from the chat, and then I'm going to go back to the people with their hands up, just so you guys know. You mentioned scoliosis. Does scoliosis affect the decision about SDR?
It makes it harder. So what happens with scoliosis is, so I do both. I do scoliosis surgery and I do this. So what happens is the nerve roots will rotate, and it will make one side very hard and one side very easy. So what happens in scoliosis is you rotate along the curve, and it buries the dorsal nerve roots on one side, and it delivers the ones to the very ventral aspect, dorsal aspect of the thecal sac. So what you have to do in that situation is there's a certain, probably beyond 30 to 40 degrees, you just can't get it rotated enough in a safe manner to do it. But I have done some children with scoliosis before. You just have to do it, and you have to be prepared for it. And
so you do have a degree level that kind of is your mark.
Yeah, once it gets beyond 60, it gets very, one side I can do very well. The other side is going to get pretty hard to do. And you know, just to say, there's some dentate ligaments that I cut, and I can rotate the cord to get at them, but it's kind of technically more difficult.
Yep. Okay, Drew Schmidt, you're up.
Okay, thank you, Dr. Leonard, for this presentation and people putting it on. I have to be forthcoming. I am one of Dr. Park's adult patients that had SDR. I've loved it. So I'm going to ask you 4 questions, and if we need to stop or you need to be reminded, that's fine. I know for your practice, you like the neuromonitoring. I know that some centers do what's called non-selective rhizotomy. Is that a safe procedure? And then my
Well,
other, go ahead.
Okay, let's start with that one. So current debate, what you're putting out is a current, depending on, there's variability amongst the various centers. TS will say that everybody needs to do selective dorsal rhizotomy, you do it. But I've done, with my training and fellowship, I did training and fellowship with him, so I've done hundreds with him to this. And what it does, the primary benefit for, so when you talk about rhizotomies, the thing that the monitoring does is you need to know your level. You need to know where you are. Number one, use the monitoring to tell your difference between dorsal versus ventral nerve roots. So there's stimulation thresholds. That's why I showed them. I covered them very briefly because of the length of it. But your stimulation thresholds, when those go to 0.5 or 1, you really have to demonstrate that you don't have a ventral nerve root. And the last one is the monitoring. You really have to eliminate the potential for bowel and bladder dysfunction, because that's important. The debate about the importance of monitoring versus the importance of the number of nerve roots cut. So I use monitoring and I stimulate everybody, but the biggest thing that I look for is I need to make sure I get to that greater than 50% level. And I have to make sure that, and then if I catch ones that are more severely affected, I make sure that I get them. I mean, that's essentially how I did today. So that answer your question for that one?
Yes, sir. And my other question, I have 3 questions, but my second question is, I know Dr. Park, he's my hero and your mentor. He prefers SDR at age 2 or 3 before they've ingrained bad walking habits. Other centers say that you don't do it at 2 or 3 because they might have underlying dystonia that might be developed later. What are your thoughts on early SDR intervention?
Well, I think what you're getting at is the practice variation that we're no one can answer that question, honestly. I think what we're waiting for is TS to publish his data as far as that goes. I think that the component, what I would also, it's not just the dystonia for this. What I would say is you also, the key component to that is the physical therapy that has to happen afterwards. I have some things online that says that I like to think of my job as easy, but then I turn him over to Christy for the next 2+ years to undergo physical therapy 3 to 4 times a week, to undergo gait training and everything else. That's hard. And you ever tried to get a 2-year-old to do physical therapy for that amount of time? It just doesn't happen. So what we don't want to do, and what I'm getting at as to why I choose sort of the 4 and 5-year-old range. There is, they're able to participate and become more willing partners at that point versus the terrible, everyone that's ever had a 2-year-old and try to see them throw a tantrum. It's just, it's like, good luck at that point. So, I mean, that's why I feel about it, but you bring up a good question. And I think that there is opportunities for study with functional connectivity and other kinds of studies that really demonstrate what kind of gait patterns and what motor function patterns happen before and after rhizotomy. And one of my former fellows is down in Houston, Manish, who is really interested in studying this.
Okay.
Can I jump in real quick, Drew? There's somebody asked a question related to Houston in Texas. And there was a question whether there is a surgeon in Texas that does children and adults for rhizotomy. And Jeff, I figured you probably would know who are the other neurosurgeons that are comfortable doing adults. Sorry to jump in. Sorry, Drew.
Where in Houston?
No, they just asked in the state of Texas. Is there a neurosurgeon in Texas that does adults?
The one with the biggest practice there is Manish Shah. He's not at Texas Children's, he's at the other one.
UT Health. UT Health.
Houston. Thank you.
Memorial Hermann. Okay. Drew, did you have a question?
Do you have another one?
Yeah, one more.
Okay.
So I know this is a more riskier procedure, and I know that some centers don't do it at all. But if you have severe spasticity and dystonia, say you're in, a developing country, do you think that combined ventral and dorsal rhizotomy should be considered?
Yes. So and we do combined dorsal and ventral rhizotomies for the non-ambulatory children, because if you just do a pure dorsal rhizotomy, you will get return of tone. So what you'd have to do is deciding with the families as to what the goals are, and sort of that's how you tailor what you end up doing. So yes, I've done both.
Okay. And last question, I promise.
And I've done it in developing countries. Go ahead.
Can you do, I know you can do a rhizotomy after ITB, you just take the pump out. Can you
Correct.
do it in reverse? Can you put in a pump after a rhizotomy?
Yes.
Thank you.
It's a little harder,
Okay,
but you can do it. You can do it.
I'm going to turn to Dr. Azizi first, and then you, Denise, will be next. If Dr. Azizi, if you still have your question.
Yes, of course. Thank you so much for this great talk. I have an adult patient with GMFCS4. She has chronic pain. I'm following her now for 5 years. She has pump. She has had 2 spine revisions, and I referred her to our neurosurgeon for ventral dorsal rhizotomy because she has very poor quality of life, not only her, but her parents as well. And in addition to pump, she's taking diazepam and and nothing helps. But the neurosurgeon hesitates to do that. One of them is that her spine she has had fusion twice, and the hardware, even you can't feel it in her cervical area. And the other reason was that he mentioned his pain, her pain is, sorry.
So where's the fusion?
Sir, I mean, it's very long, all the way to pelvis.
Oh, it's all the way to pelvis. Okay. Yeah, it will. The fusion will make the rhizotomy very hard to. It's not that it can't be done. Have there been intraspinal procedures?
Sorry?
With intraspinal procedures?
No. So I mean, I know she failed one time. They had to go out, but it's a long time ago. She's now almost 27 years old. And the other reason that he mentioned is that her pain is not. She has pain in her neck and uppers, and so he's not sure even if we do ventral dorsal rhizotomy.
Yeah, if that's the primary problem, that's not somebody that I would subject the procedure to, because they would probably have the same payment afterwards, if that's the primary problem.
Okay, thank you.
Okay, thank you.
Denise, you're up with what's possibly the last question. We shall see.
Okay, thank you so much for this talk and information. I just want to follow up on my earlier question around whether SDR should be local or not, just to understand. I think what you're saying is that you will monitor everywhere and cut where you see that spasticity exists, but when you cut, you want to cut more than 50%. Is that? That's correct. Then that's correct. Okay, thank you. Then the other thing I think related to that is it also true then that it's very rare that spasticity only is focused on one muscle group but not showing up anywhere else, even though maybe clinically we cannot really see it? Is that also true? Or should I think that it's very common that for people to have spasticity in specific muscle group?
There's wide variability in presentations. So yes, you can have, and I have a number of patients that will come in and just be toe walking and tripping. And essentially those are the children that when you do a rhizotomy, you can return into almost normal ambulation with this. Does that answer your question?
Yeah, so I think my question is that because if you are only seeing spasticity clinically in, let's say, ankles, is it true then when you monitor them in the surgery, typically you actually see spasticity across multiple areas, or
okay, normally in those, when you see it and it's just in the ankles, you will see when you test your nerve roots, you will generally see them just misbehave or have the higher stimulation thresholds in the lower. So when you do the conus rhizotomy, I will be able to group them in lumbar. There'll be lumbosacral, L5S1, and then pure sacral. So that's what you end up seeing. And I left out about another 30 minutes of talking about localization and stuff that you can really do in the rhizotomies. But it allows me to really focus the stimulation and everything else if you really want to make sure that you get those ankles loose. Does that answer your question?
Yeah, thank you.
Okay.
So Dr. Leonard, one last question and then we're going to wrap up, because I think you can answer this one and we'll have just taken you 15 minutes over. Has SDR ever offered in non-CP patients, specifically in spinal cord injury, to reduce spasticity?
Yes, transverse myelitis too. Transverse myelitis and a number of other brain malformations. So holoprosencephaly, schizencephaly, and other things where they have, that's like, for instance, schizencephaly, which is a unilateral brain malformation. They can have hemiplegic kids, and those do very well after rhizotomy.
But what about spinal cord injury?
If they're further out, yes.
Further
You have
out?
to make sure. You have to make sure spinal cord injury will vary during that first year, and the degree of tone. What you need to make sure they need to be multiple years out, and they need to have not had a fusion, because it gets really hard to do it if you've got a fusion to fix their spinal deformity.
Great. Dr. Leonard, that was jam-packed with so much information. Thank you so much for spending the time. Thanks for going over so that we can address everybody's questions. Everybody, thanks for tuning in. We will post the recording if people want to come back and hear a specific part, and for everybody else that couldn't make it. So thanks a ton. Greatly appreciate it. Job well done.
Thank you.
Thank you.